Welcome back to another episode of Sports Medicine on Tap. My name is Brandon Online. I'm sitting at a pretty busy neck of the woods brewing company in Pittman, New Jersey with my good friend Dr. Frey. How you doing?
Spectacular.
So glad to be back. We took a little hiatus, took a little bit of time off. We just had life happen like kind of it always does.
Yeah.
And tonight we have on the phone one of my good friends, Dr. Shawn Hanlon, assistant professor from Cal State Fullerton, all the way out in California. So Shawn, welcome to the show. And thanks for coming on, and especially with the time difference and stuff, we appreciate your time.
Heck yeah.
Pleasure to be here, Brandon. Glad we could do this.
Yeah. Shawn and I, just a brief intro on my end. Shawn and I go way back as far as he was my undergrad tutor, and then he was my boss at one point in time, and now he's just a lifelong friend, and we've been to each other's weddings. My kid calls him Uncle Shawn, so this is an awesome time to get one of my good buddies on who also happens to be an expert in our area of focus tonight.
It's spectacular. Amazing timing.
Yeah. So if you don't mind, Shawn, I could go on all day about you and tell people all kind of funny stories and whatnot. So if you don't mind telling people about yourself a little bit, and then we'll dive into kind of what we're going to talk about tonight.
Yeah, absolutely. Thanks for keeping all the great stories to So my background, I'm a certified athletic trainer and a strength and conditioning coach. I worked professionally for about 7 years full time before going back to pursue a PhD. So my PhD is from the University of Delaware in biomechanics and movement science.
Right.
And my expertise there in my dissertation really centered around Achilles tendinopathy. My pre-doctoral mentor, Dr. Karin Silbernagel, essentially, I don't think you can say her name without thinking about Achilles tendons. So I've had a very fortunate training when it comes to, how do we manage these things. And then I went on to do a postdoc at University of Colorado. I was there for 2 years working in rehabilitation sciences. And now I'm a professor out here in California for the athletic training program, the Master's in Athletic Training program at Cal State Fullerton.
That sounds like a terrible track you were on. For those people who don't know, like University of Delaware, is a big player in this particular, in this world, right? Like in terms of physical therapy, athletic training, it's excellent. And then you go to Colorado and then to California.
Yeah.
Oh man, it sounds awful.
I try to keep it, in check.
Yeah, right. So with that being said, Shawn kind of gave a little hint to it. He's quite the expert in Achilles tendinopathy.
Right.
And what better conversation to have than one of the faces of the NFL right now, Christian McCaffery, who's had this crazy injury history and story kind of go out, and then recently getting put on injured reserve IR, missing multiple weeks, up to at least 4, with what started off as a calf strain, or reported as a calf strain, and then became diagnosed and reported as Achilles tendonitis, and now it's leaving so many people scratching their heads and like, what the heck happened?
Yeah.
How did this all kind of come to fruition?
And how come I haven't won a game in my fantasy league yet?
Yeah, exactly. Why is my fantasy football team so bad? Because I drafted Christian McCaffery. Exactly right. So, Shawn, if you don't mind, what are your thoughts on this whole situation? Right, like I have a couple notes here of just. We went over this in our last show too. He went all the way back as far as August 1st. It was reported, so we're over a month and a half ago now. It was reported he had a calf strain, and then just this past week, about September 9th, he was then ruled out from a Monday Night Football opener, and the diagnosis changed. Now it's Achilles tendonitis, and now it's a long-term issue, and it's projected 4+ weeks of being out of play.
Yeah, there's a lot of speculation that we're about to delve into here.
Right.
So I think my initial thought on this is, was it in fact a calf strain, or were these symptoms consistent with Achilles tendinopathy all along?
Right.
So I think chicken or the egg, we think about, were the symptoms related to reduced muscle performance, or is hot? I'm assuming, at this level, we're doing periodic performance testing just to make sure that muscle strength and power are staying consistent.
Yeah.
I guess there's some force plate data involved. And so I think about this a lot where, Achilles tendinopathy is a silent disease. It really manifests for several months, if not even more than a year, before it finally shows up clinically as, pain and loss of function and reduced performance. So thinking about this, in the time that that we're talking about here, it's not that shocking to me that this, hasn't completely resolved itself. And then who knows what the training schedule was like in order to eventually get symptoms to finally show their face in the Achilles tendon, and was it there all along?
You said a lot of speculation here, and I'm going to seize that opportunity to throw out our disclaimer that we don't actually have any access to Christian McCaffery's actual chart, medical information, and whatnot. We're just sort of speculating on these types of injuries based on what we know in general and what information has been released publicly. But so with that in mind, I find it interesting that the way you presented it, that like it's sort of this silent thing that's tendinopathy sort of developing over this period of time. So it was originally presented as a calf strain, and now it's, I think, being presented more, like you said, like as a Achilles issue, tendinopathy. Do you think that's where he's having pain change, and that was the source of the change of the diagnosis? Or is it sort of the inability to recover, or slow recovery? Or clearly these things do take time. Like we do, Brandon and I do a bunch of these shows, and one of the shows we do frequently is sort of this NFL pre-show, and that was one of the things we had talked about, is the fact that like buyer beware. Like, he's an unbelievable athlete, a game-changing athlete, but these particular issues, these calf strains, hamstring strains, these things, they could be a nuisance and be a real problem. Buyer beware. Do you think that this whole thing has been developing for a while and sort of miscategorized, or do you think that there's been an evolution in his injury? It went from calf strain to more of an Achilles issue.
How this started, we're going to trust that, with all the resources that an NFL team has, there was absolutely imaging that was completed, in my mind. So my thought here is that, this was a calf strain and it was managed. What we sort of don't see under the skin is the development of Achilles tendinopathy could potentially have developed here, as you said, like an evolution. The soleus really takes up, 2/3, almost, I think it's about 30% of the force production when we go into plantar flexion, especially, in these types of, football related movements. So if you have a calf strain, and we don't know if it was gastroc or soleus, but my money's on soleus. We would then have a reduction in the amount of force that we can produce from that calf muscle. And if we have this limitation or this change in loading over several weeks, several months, your tendon is not going to get the same amount of loading it needs in order to stay strong and stay, relatively stiff. So my thought here is that, this is probably developed into something where he could have been teetering on the edge of developing tendon symptoms. What we typically see is elite athletes, they are kind of always teetering on the edge, right? You're trying to optimize performance, push yourself to be stronger than the last week. So I see this as something that probably developed, in concert with the calf strain, and now we have two problems that we're dealing with.
I think Brandon and I probably have like another 30 questions lined up for you, but before we go down that road, you just hit on a couple different topics, or a couple different things I think are important to mention. Can you tell us a little bit about the anatomy here, the gastroc versus the soleus, and how they play a part in, with the Achilles tendon, and kind of what they are and what they're just the anatomy back there?
Yeah, absolutely. So completely, both gastrocnemius heads and the soleus do converge into what we call the Achilles tendon. But there's actually been some good dissection studies that show how the tendon fibers of each of those muscle bellies wrap around each other and then converge to meet at the calcaneus, at the heel bone. One of the things I think has been really brought to light in the last few years, just with better imaging and more robust studies, we're finding that the soleus is really the mover. Our gastroc doesn't really get that much of the loading, and we think about if you bend your knee, we quiet the gastroc, but that's not really the case. The soleus is active in every position of the knee.
Mm-hmm.
So you get something like this, and especially thinking about sprinting and change direction,
Right.
your soleus is the one that's doing most of the work. And so you think about the hypertrophy that can happen in an elite athlete. If we neglect the gastroc, it's almost, an additional muscle you have to train, because the gastroc just doesn't get the same amount of loading that the soleus would in typical football training.
Right. I would say similarly, right? Like you have your biceps brachialis, and then, or your biceps, and then you have your brachialis, which underlies the biceps. And biceps crosses two joints. It crosses the shoulder joint and the elbow joint.
Mm-hmm.
And then your brachialis is on the humerus, just crosses the elbow joint. Similarly, hamstrings cross two joints. And these are muscles, muscle bellies, and tendons that tend to get injured often, right? So
Yep.
gastroc crosses the knee joint and crosses the ankle joint, whereas soleus does not cross the knee joint. Soleus comes off the back of the tibia, and so it's only crossing the ankle joint, one joint. And I actually think, that plays a big part in this. And you see that kind of over and over within the human body, the joints or the muscles, and there aren't that many of them that. The muscle tendon units that cross more than one joint, top and bottom, tend to be the ones that are really subject to injury, tear, strains, all of that.
You have a point there, right? It's like one of those weird, interesting muscles, or like just the muscle group itself, right? Because then we're talking about this, strength difference relationship and all that other stuff. And I think with this being said, with the chronic nature of this, and I think what Shawn kind of pointed to, like this is something that could be manifesting over time. Now, we rewind the clocks a little bit and go back to the Super Bowl pre-shows. Yeah. We talked about Christian McCaffery having a calf problem back then.
I know.
So we're talking like this is not just a problem that's just as of August. Like this is something that was end of the season. He played through it.
Yeah.
And then, after the season, there's a period of rest, right? Like there's a period of rest, and I'm sure he felt a little bit better.
So.
You would think. He gets some time off, he gets some time to rest, and then he ramps back up in training camp, and then that's when then happens again, and then it happens. So I think to speculate, and based off what Shawn was saying, is that this could have been something that's been going on since, the playoffs, NFC Championship, and the Super Bowl, and then just because of the offseason, this not misdiagnosis, but this evolution of this injury kind of occurred because of his training changes.
Yeah.
He probably took some time off and started to ramp back up, and then once he got back on a football field for camp and to do all these dynamic movements, that's when he gave out again.
Sure.
Yeah, and I think this brings up an important point too, that in general, if we're chasing symptoms, a calf strain is going to completely recover from the subjective of the athlete. Once the pain's gone and I can sprint again, I'm good, right? I'll just go back to my regular training routine.
Yep.
But the reality is that maybe the calf strain altered, the amount of force that we're putting through that tendon, and we've then gone through several months of an altered loading profile for that tendon, and now we're seeing the later effects of that.
Right.
Yeah. I don't know if this has been talked about, and I imagine it has been. Have they sort of released or given out the information as where he's having the problem in terms of along his Achilles calf? Is this a muscular tendinous junction issue? Is this a mid tendon issue? Is this an insertional tendon issue? Has that information been released? Does anyone know?
I don't think so. I'm usually pretty good at trying to find that stuff.
Yeah.
And it's funny that you phrased the question that way, and I was going the same direction of it, of trying to explain the difference between the three things, right? Like, because it's not just Achilles tendonitis is just, I think Shawn would agree, is just such a vague umbrella term, but there's so much more to it, and I think the treatment and the diagnosis of it changes a little bit on the location.
Yeah. What are your thoughts here, Shawn? What are your if you had to venture a guess, and we get it, it's speculation. What are your thoughts?
Yeah, so I'm inclined to think that this is a muscle tendon junction location. So when we discuss like what is Achilles tendinopathy, we typically break that down into insertional tendinopathy, which is where the bone meets the tendon. So that's like pain inside your shoe, or the mid portion tendon, which is like 65% of cases. That's like the pinchable area just above the back of your shoe. Right. And we typically consider like 2 to 6 centimeters above the heel bone. That's your mid portion. Now you can be on the mid portion and not be able to feel that your soleus is actually kind of a handshaking position underneath the tendon. It wraps along the bottom of the deep side of the tendon.
Yeah.
And some people have very, very long tendons, and we can clearly see where their muscle bellies start and stop. But a lot of people, and I would venture to guess, Christian McCaffery is somebody who has a very short Achilles tendon. It goes down, and so his soleus is very long. It travels down further, closer to the ankle.
Interesting.
Right.
And I say that because in my experience, people that are really good at changing direction, it seems like they have very short Achilles tendons versus people that can jump 5 feet up in the air, like they're built like a spring. They have very long tendons.
What if you can't do either?
My guess is here, we think about missing an injury, and I doubt anyone missed anything. I think we thought this was muscle belly, and now the symptoms are lingering further down and it's acting more like a tendon injury. And so that's where I think we're dealing with a bit of both. And what that does for things is it complicates. Why do we give people this many weeks out, or why do we manage it this way and not that way?
And so before we go ahead and dive into the management of this, I just want to give a quick shout out to one of our sponsors, Virtual Orthopedics and Spine. They have you covered from runner's knee to dog walker's hip to yard work back and laptop wrist. They have a doc for that. So find the right specialist for you at virtua.org/ortho.
Right.
So to go into a little bit, like you kind of said, like it's kind of all these symptoms and, area of actual injury and what's actually causing the problem changes a little bit of the management of it. So what are your thoughts on the timeline of it, right? Like I've read reports that, in the NFL, if you put on the IR, you're at least a minimum of 4 weeks, you're out. And then I read reports of this could be even a 6-week thing or even a little bit longer. So what are your thoughts on that? And what does your expertise say in like recovery timelines and things along that nature?
With the limited information you have.
Yeah.
Right.
So let's start at the minimum diagnosis of tendinopathy.
Sure.
Yeah.
Because it can be such a roller coaster of, symptoms on, symptoms off, and then let's go try running again and symptoms return. I actually applaud the medical staff for taking a conservative route here and trying to extend the minimum time.
Yeah.
Right.
The sooner we go back, the less control we have over the loading environment that we are subjecting the tendon and the muscle to.
Right.
So by giving them that 4 weeks, we can potentially get on top of the symptoms and understand just how much we can load. And by that, I mean how many steps, how many sprints, how many accelerations and decelerations before your symptoms come back.
Right.
And we call that load tolerance. So my guess is they've done something along these lines and have determined that he cannot tolerate the demands of a full game without symptoms coming back. And they're being smart about this with the long game in mind. We want him for when the games really matter.
Right.
The first few games, that's, whatever. So let's be smart now, get this thing under control, and then we can then be smart about when to play him. What do we do in the days in between games? And maybe we maximize our chance of having him for the big games and playoffs.
Right.
As for the calf strain, I think that's where the minimum 4 weeks really lends itself. Like if it is a muscle injury, we know that muscle tissue will regenerate, will scar down in 4 to 6 weeks.
Right.
Yeah.
So that maybe covers all manner of injury, and we get the benefits of being able to completely control what types of loads go through that Achilles tendon.
Yeah, and I think that's kind of like, like you said, like the management of it and how they've been treating it. And I think what you said is almost exactly what kind of I read. Like he kind of hit a point where he couldn't he couldn't withstand the load anymore of what they were doing. And that I read in like one of the articles when I was doing some research about it, is like he just had a day when his pain was at like it was his worst it's been. And I'm sure it was in the process of trying to return to play, try to get ready for this Monday night opener game. And they just said Monday was his absolute worst day. And he just had one, and that's when they kind of, the red flags came up. And that's when it was like, all right, this is more serious. And then I think that like followed right into the diagnosis and the new reporting of that is now an Achilles tendon issue. And that now he's out for a long period of time. And then, like you said, the long game is the biggest thing, and it's one of, he's not just a franchise running back. He's like the face of the league right now. He's on the NFL Madden cover of the video game.
That's why all this is happening.
This is all I thought. He's got hit with the Madden curse because that's the thing. But it's just crazy that it kind of happened that way, right? But I think it's just what you said is just exactly what happened. It's just the calf started, and they tried, and then they hit a point where it's like, this is not good, and we got to go back now. Everything falls in this long-term window, and to get them back for when it matters.
Yeah, and I think you bring up a good point too. That this man is, could arguably be the face of the NFL.
Yeah,
we're gonna want him around for a while, and if you don't manage this injury appropriately early, it'll just linger. It'll come back season after season, every year until he retires.
And then, or even a worst case, it gets to the point where it's real bad, and then the Achilles tendon ruptures.
Right.
And then now we're having a whole different discussion, and it's arguably could be a little worse. And having a surgical intervention is not something you want to be a star running back.
Yeah. And if it's muscular tendinous junction, typically, he's not heading down a surgical pathway, but there's some ramifications for that. Like if you start losing the structural integrity at that particular point when everything's lengthened a little bit, and maybe he's not the same player that he was, and from a surgical standpoint, it's really not an easy thing to fix, right? Like it's hard to sew a tendon to muscle. It just is. Muscle doesn't have great strength, pull out tissue, whatnot, and it's like it's like trying to sew through like cheese. I don't know. It's a bad analogy, right? But it just doesn't hold very well.
Right.
Sewing through leather, that stitch will hold. Sewing through something like cheese, it kind of pulls through. Like it's not great. So you don't want this to become a bigger problem than it was. I also wonder, now this is just me being a little bit cynical and jaded, how much does the emergence of Jordan Mason in week one, like all of a sudden say, hey, we can take our time a little bit. This is our guy. We know he's our guy. He's phenomenal. But we're not really in dire straits right now.
Yeah,
you know what I mean?
I would venture to say that it makes the telling or, coming to management in a pro professional level is that saying that your top guy's out, but the backup's still putting up 100+ yards a game.
He's played great.
Scoring, and doing everything well, it makes this decision a lot easier, right? Like, and I mean, Shawn and I have done it. We've worked together and done this and managed people throughout a season. And it's just like when the person who's in the backup is doing really well and the absence of the starter isn't noticed, it makes your job a little bit easier.
Yeah. And then how about the fact that he gets on the, right after the game, Monday night game. Was it Monday night?
It was a Monday night opener. Yep.
And at the end of the game, I forget who was doing the interview. I'm sorry that I forget, but he gets asked, like, when did you find out you were going to be the starter? Assuming it was probably like 3 hours ago. Yeah. And he answers Friday.
And the rookie said Friday, and he kind of spilled the beans a little bit that he kind of showed his hand.
Right.
Just a little too much. And
I don't know if that was the right answer.
Yeah, that definitely wasn't the right answer for that young guy there. And I'm sure, like, I think, with that being said, is that it's not uncommon for those discussions like, well, this is probably not going to look out too well. But the strategic advantage, if you will, is you hold it out to the last second when you're planning to play against Christian McCaffery versus planning without him. Yeah. It's a much different game plan.
Yeah, for sure.
So I get that aspect, I guess.
Absolutely. Yeah.
So I guess that's, the next point is like, so what's the rehab and what's like the best evidence right now, Shawn? I mean, when I'm in the clinical practice and I have an Achilles or a tendon option or tendon issue, I always want to call you and ask you if I'm doing something wrong or doing it right. But
you absolutely should.
I know. I need to call you more often. Well but said. Like, what's that rehab look like, and what's that treatment of that look like? And I think, from knowing you personally and listening to you talk plenty of times in different lectures and different symposiums that it's a little different than I feel like what most people do, and it's just. There's still some misconceptions on what you should or shouldn't do with these tendon issues.
Yeah. Oh boy, where to start? Let's start with what we should do.
Yeah, that's fine.
I think there's the perfect world treatment response, and then there's the real world treatment response. Right. For this type of injury, and I think Brandon, you remember us talking about this. When we used to manage injuries and co-treat.
Yep.
If you're an in-season athlete with a tendinopathy, my goal is not for you to recover completely and achieve complete healing.
Right.
I almost relabel it as it's survival. We are
Right.
trying to manage your symptoms,
Mm-hmm.
and that might just it might look in the form of protecting your time, and maybe we take a short, brief period away from sport, full, unrestricted, activity,
Mm-hmm.
in order to basically get symptoms under control.
Right.
And that's kind of where my treatment approach begins: is symptom management and load control. I have to identify what's the root cause. What are we doing here that's overloading you? Is it too many reps? Is it too much load? Too frequently? Are we not giving you enough recovery time? And so how can we break this overload cycle? That's kind of the focus of phase one for me. And
Right.
it usually does come while you're in the middle of your season for athletes. And then once we can identify the issue, the name of the game is reintroduction to loading. If we want tendons to remodel, we need to give them adequate loading. And by adequate loading, I mean we need enough stress to go through that tendon that we get a little bit of stretch.
Mm-hmm.
So for some people, that means we need to work on your soleus and gastroc strength, and the muscle needs to be strong enough to deform the tendon when we load.
Mm-hmm.
So that's kind of leaning into this idea of this of Christian's case. Maybe that's what happened here. We didn't have enough strength in the muscle to maintain good tendon loading, and so the tendon slowly but surely got a little weaker. Once we've gone through, typically I'm prescribing people body weight calf raises every single day. I always say, like, if you don't want cavities, you should brush your teeth.
Right.
And if you don't want tendon pain, you should do body weight calf raises every day.
Mm-hmm.
So we follow the Silbernagel protocol in my clinical practice. So it's essentially 5 different body weight exercises. You're doing double leg, single leg, up with 2, down with 1 eccentric loading, and essentially like a seated calf raise. And then once you're ready for it, we start increasing the rate of loading, so how fast you're moving. But we start people off with slow, controlled muscle contractions, trying to get that muscle to wake back up and be strong again. And then as we get back to, they can load again without pain and their symptoms aren't coming back the next day, we're progressing people to external load. All right, let's put weight on the barbell. Let's get something heavy in your hands, or put a weighted backpack or weighted vest on, and overload that muscle and that tendon again. And as people can kind of tolerate that over time, we increase weight. We're looking for their pain monitoring as well. So how much pain do they have the next day? If they're waking up the next morning with more pain than they woke up with the day before, I probably overloaded them.
Right.
And so I'm trying to keep people in this happy medium where I'm giving them tendon loading, but I'm not overloading them and making the problem worse.
Right.
And so from there, you just follow general strength conditioning principles. If they can produce 3 sets of 10 with no problems, then we need to maybe bump up the weight next week so that they're struggling to get number 10.
Right.
You can use intensity, RPE scales, things like that. But the grand scheme of things, if you look at the literature, most clinical trials end at 12 weeks. And so we've misconstrued that at 12 weeks you should be healed.
Right.
And that's just simply not the case. Physiology argues that it takes longer.
Yeah.
So we extend this deadline to, honestly, up to 6 months to a year.
Wow. Yeah.
The more athletic people with less detriment, they don't have as many functional deficits. Their muscle strength was always good. They're just overloaded. We just got to identify what's wrong and remove that training load error, and they will get better in 12 weeks.
Right.
But the people that have, degenerated tendon and muscle atrophy, there's problems at the neuromuscular level, they're going to need 6 months, maybe even more than that.
Yeah.
I think that timeline, sometimes the longer aspect of that is just unthought of, or just people don't really realize it in the world of sports.
It goes by
medicine.
the wayside. You start to feel a little bit better, and
start to feel a little better, and so you're good to go. And then you kind of miss and correct it, and then or you miss the opportunity to correct every little thing, and then down the line, it's like now you're chronic. How it's every season with this kid or this athlete or this patient. It's like every time we do this, it comes right back or whatever, because we're missing the final step.
And that's kind of what we've learned, unfortunately, through retrospective lenses, is that we can get people feeling better and running again.
Yeah.
But if we don't address their tendon structure and we didn't get that image to look at if there is, some deficits underlying, we let people go back to play because they pass our functional tests with compensation, and we didn't. It's just too subtle for us to notice.
Right, you can't.
And so we
catch
call it a re-injury, but in reality, it's just symptom resurgence. We never got to the root cause, and 6 months later, sure enough, it's back.
So, and these are notorious for that, right? These recurrent injuries and whatnot. I got to tell you, I love what you said about the kind of like, when I'm talking to patients, I put it to them in a slightly different way. And it's a little bit nebulous, but I talk about kind of like this envelope of function, right? Like, and in general, as you get older with time, the envelope of function, everything that you do that you can do and get away with without causing injury shrinks down. It gets smaller and smaller over time. And you can increase that envelope of function. Like people, like one day, they can run a marathon. 12 years later, they can't, right? Like, but you can increase that envelope of function by doing the right thing and staying on top of it, exercise wise, and just like you're saying, like correcting whatever underlying issue there has been. That like as you get older, you can no longer compensate quite as well to make up for that deficiency. You actually have to correct the deficiency, and then once you do, then you can increase the activity level. You can expand the envelope of function and start to do more within that without actually re-injuring yourself. No, I think that's a kind of a fantastic way to cage it and to think about it, to not only solve that particular problem, but to solve the recurrent or the next injury that's coming down the line if you don't make the correction.
Right.
I'm gonna throw a few different things at you, Shawn. I'm kind of curious to get your take on it, and this sort of flies in the face of what we just said in terms of correcting the problem, but in terms of symptomatic relief or symptomatic treatment, I think there's a little bit of controversy on both sides of the issue, which direction to go in. And, and sometimes it could be one or the other, but I'm going to go kind of in both directions. Tell me what you think is the better way to go if you're trying to treat one of these. So, all right, you have an Achilles tendinopathy, someone's being very limited. Is your go-to initially or throughout the treatment, do you go ice or heat?
I
know, controversial.
I guess I didn't. That's not what I thought you were going to ask me.
Oh, okay, sorry.
No problem.
Yeah, I got a bunch of these in a row. So
no
this is
problem.
number one.
Yeah. Well, I think it's a contextual question. Yeah. If we are simply looking to resolve symptoms and get some tendon pain under control, then ice is going to be our number one analgesic. Mm-hmm. If we are looking to recruit, tissue extensibility, and we're trying to, maybe get some blood flow to that tendon, then we're going to give it some heat. But my personal opinion is I'm probably going to give them neither.
Okay.
And I'm going to try to do some different things that would maybe, perhaps, induce some analgesia. So we're thinking about there's evidence that kind of goes back and forth with isometrics,
right? And
maybe that can have some neuropathic endogenous pain relief.
Yeah.
Maybe it doesn't. The research is kind of on both sides of the coin right now with Achilles tendons, that some people it actually makes things worse.
Right.
Some people it does eliminate their pain for up to 45 minutes, and then some people it doesn't respond at all.
Right.
Any role for NSAIDs or steroids?
Yeah, I can definitely speak to that. There really isn't a lot of good evidence out there for supporting NSAIDs. The nature of Achilles tendinopathy is not inflammatory in nature. Right. So by the time we're seeing these cases, anything that NSAIDs are meant to inhibit and help is not there. Mm-hmm. So if the pain is unbearable, like you're unable to complete activities of daily living, you can't push the gas pedal in your car because of the pain. Mm-hmm. Maybe some antipyretic like Tylenol, it would be a better option.
Right.
And then the corticosteroid injections, I'm against them.
100%. 100%. I agree. Yeah.
We just don't have any research yet to support their efficacy,
especially there.
But we have plenty of research to show what happens when we have too many corticosteroid injections.
Right.
Immobilization or activity?
Absolutely, activity.
Yeah.
The immobilization, if we think about, tendons like to be loaded, immobilization eliminates that load. And if we eliminate the load, the tendon will weaken.
Any role for needling or PRP or anything along those lines?
Yeah, that's an interesting one. So there's one paper out there right now for needling, for dry needling.
Yeah.
Okay.
And again, you're not actually needling the tendon itself. You're needling the muscle.
Mm-hmm.
So I think it's beneficial for people that have the muscle inhibition component that I mentioned earlier, with thinking about the same with like the calf strain leading to tendinopathy.
Yeah.
I don't think it's a be all end all treatment, and I think it really only has a small window of opportunity. And then PRP, there is still zero evidence to back PRP as a good option.
Blood flow restriction.
Blood flow restrictions on the up and up.
Yeah.
There's a pilot study that just got published maybe last year, showing that the low load BFR protocol is beneficial for all the benefits for muscle. So we think about the people that are too weak or too painful to do a body weight calf raise.
Right.
BFR is a great option for those people.
Right.
But again, I think there's an expiration date on that as well. Once someone is strong enough to load their tendon against gravity, then we probably don't need BFR anymore. We can probably switch to putting some weights on them.
You want that stress on the tendon. Yeah, agreed. And then types of stress, right? Like, and you started to allude to this, isometric versus eccentric.
Yeah, so I like to tell everybody that the tendon doesn't know whether or not it's being loaded eccentrically or concentrically. It just knows load.
Right.
Mm-hmm.
So when you think about your goal and the loading environment that your tendon can tolerate, we can definitely put more load through a tendon eccentrically than we can concentrically, but that might also be overkill. So the evidence would tell you that it doesn't matter. Eccentric protocol only, eccentrics plus concentrics. If you Google our protocol, it's a combination of all of them. And when you can't perform an isotonic exercise, then we will put in isometrics for you.
Right. So it's interesting. That was the first one where I think you strayed away from where I thought about it. Like where I think like early on you do some isometrics, and then then I traditionally I think of these as eccentric strengthening is the way to go. But you didn't seem to go down that road. I thought the way you answered every other one was like kind of that I think is sort of the accepted norm at this point. That was interesting. Little curveball.
Yeah, the Håkan Alfredsson is the surgeon who developed the eccentric protocol.
Yeah.
And so it's been it's probably the most popular, most well-known treatment protocol that exists.
Right.
But in the last decade, we have come up with multiple variations of loading programs, and everyone wants to know what's the best way to load the tendon.
Right.
And the summary that keeps coming up, every paper, every answer, every clinical trial says it doesn't matter. There's patient preference.
Yeah.
And maybe if you're somebody that has a lot of degeneration in your tendon, like it looks pretty bad on ultrasound, you're very weak. Eccentrics, maybe we get more tissue turnover because we're loading it so aggressively.
Okay. That makes sense.
Yeah.
And then, do you have any more?
No, that was the my rapid fire round.
Yeah, the rapid fire round there. So then I guess you kind of alluded to it a little bit in talking about ultrasound. What is the best way to diagnose these type of injuries, clinically? MRI, ultrasound, X-ray, CT scan, whatever it could be. What is the best option?
What remains your best option is your clinical expertise and presentation. Okay. By definition, we're diagnosing tendinopathy if there is pain on palpation, pain with mechanical loading. So when I use my tendon, it produces pain, and a mechanical loss or reduction in function, meaning, I have pain when I walk. I no longer can sprint to my max speed. There needs to be those are like the three caveats, and then it just comes down to location of pain. When we talk about diagnostic imaging, ultrasound is should be the most readily available for evaluating tendons, because we can look at all those different soft tissue factors as well. X-ray is not going to be informative, and the main negative of MRI is it's not in real time. We can't have you contract your muscle, and we can see the influence on your tendon.
It's not dynamic.
Not a dynamic study.
Exactly.
Right?
Yeah. And then really, I use ultrasound for what else is it? So is there a bursa involvement? Is it actually just the paratenon around the tendon that's irritated?
Well said, yeah.
Is your tendon perfectly fine and you just have a hypertrophied plantaris tendon that's taken up space next to your tendon and we're getting friction? So we use it more for differential diagnosis and identifying contributing factors. You think about like calcifications that are in your tendon or wedge their way in between the tendon and the bone.
So I got to say, you must be and clearly are a fairly skilled ultrasonographer, because everything you're saying makes absolute sense. But a lot, it sounds nuts, but it's difficult to find people skilled in the things that you're talking about in the U.S. It's shockingly, right? Like in Europe, it's a much more commonly used modality. Treatment is part of the treatment algorithm. In the U.S., we tend to go MRI. And you can actually see so many additional details if someone is trained and good at looking for these things, just like Shawn is talking about, and especially the dynamic portion of that equation. It's something that it's continuing to grow in the U.S., right? It's getting more and more readily available. But even still,
and in my opinion, it's the future. That's going to be in clinical practice. It's going to be in PT clinics. It's going to be in athletic training clinics. I'm pretty sure every sports med fellow that I've worked with in the last 5 years, it's part of their didactics and curriculum.
It's a big part of
their
their
learning musculoskeletal ultrasound.
Yeah, for sure.
Yeah, and I think that's something that to a little bit about that is that, Shawn did a presentation at our National Athletic Training Association about this ultrasound and the importance of it. And I think that was like one of the big take-home messages of it, was just how informative it actually is. And to see it real time. Right. And, in the session that he had, that he was, the host for, if you will, we were able to see all these different people in the room of just athletic trainers who are at the convention, just differences in just, in my little breakout group, I had AT who had a patellar tendon injury from way back when. Yeah. And we compared the two, both sides. And that was like the first time I actually really sat down. I was like, oh, wow, there's such a difference.
Disorganization.
And it only took, I don't know, it took like a 30-minute lecture, and then we were in the clinic in the lab setting for like 20 minutes. You could already see the importance of how this could really change the future, if you will, and like how it can change your clinical practice and just give you a little bit more. I mean, it doesn't give you the X-ray vision that you always do, but it gives you another, to look in the skin a little bit. Pretty damn close, right?
And it's not, it's fairly inexpensive, right? Like once you have the machine, it's very inexpensive, right? And then it's no radiation. Like you can do it like in like you can do it in a locker room, you can do it in an office, you can do it like any setting. It's very, very accessible.
It's safe to do it on babies regularly, right.
But you just have to have that basic, and it does. It takes some learning and it takes a lot of exposure. And there are a lot of subtleties to it, and there's a skill to it too. There truly is. It's not just knowing the anatomy. I use ultrasound when I'm doing injections. That's why I do a lot of ultrasound guided injections. But lots of times I'll tell patients, like, let's say I'm doing a rotator cuff and I see what I think might be a tear or a partial thickness tear and whatnot, and I'll cage it. Like I'm using the ultrasound. I do a lot of these, but I'm really like looking where the tip of my needle is, making sure the injection's going into the right spot.
Right.
I see some stuff. But the truth is, I'm better at reading an MRI than I'm reading an ultrasound,
right?
And it's just from experience, right?
Yeah.
But if we got to a point where we're better at reading the ultrasound, because it does give you more information. Mm-hmm. Like first, from a cost standpoint, you save tons of money across the board,
and second,
time, and so much time. It's right there, and it gives you more information. Yeah, that's a great skill to have, man. It really is, Shawn. The more we promote it, the more we kind of sell that. Like it's just the better off things are. So from a structural standpoint, are there people that are somewhat predisposed, a little bit of a cavo-varus foot, or like so high arches, or flat foot, pes planus, or anything in particular that you feel like, this goes hand in hand with Achilles tendinopathy. This goes, any of the plantar chain type injuries.
There are always going to be biomechanical inefficiencies that kind of set people up to have different angle, if you will, between the tendon and the bone at the foot.
Yeah.
So yeah, it's been identified that if you have an excessive amount of pes planus, we did an interesting study where we looked at the foot posture index. We had like over, I think, 60 people in this, and it seemed that foot posture was it was all over the map with patients that had Achilles tendinopathy. So we weren't really seeing a pattern in our cohort of like foot types and what maybe could relate to developing it. I think it really comes down to the training environment, the intrinsic factors that we talk about and extrinsic factors. The training environment and what kind of loads that you are typically subjecting tendons to on a daily basis, on a monthly basis, and then adequate recovery outside of those loading bouts and training exercises, things like that. From there, the only other main thing that we think about is more systemically, people that are pre-diabetic, people that have increase in like cross-linking in the tendon just from lifestyle, older age, things like that. But when we think about, everything else, yeah, we can maybe, if you're a 4-foot striker, you're going to have more load through your tendon.
Right.
But there are still plenty of people that are 4-foot runners that don't develop Achilles tendinopathy.
Right.
So, we're still trying to figure that out. I think we have some studies, what the statistics will tell us and then what's real world, obviously things like alcohol consumption, smoking, yeah, they're linked to relatively low, sedentary behaviors. So maybe is that a good thing that we are less overloading our tendons?
Right.
Probably not.
So I think when it comes down to is we joke and say like, I wish I could predict who gets tendinopathy.
Yeah.
You could give two people matched up all the same loading environment, the same training program, same diet, and it seems like if you're going to get it, you're going to get it. And then we got to, put you back together.
Yeah.
That's right.
Well, I think this was quite informative on many different levels. And as always, Shawn, I do appreciate your time. Is there anything else that you want to touch on, talk about anything else or any, news, exciting things that you're working on that might be coming out soon or anything like that along those lines?
Yeah, absolutely. I think the big clinical take home for this is if it is true tendinopathy with McCaffery's case, it is going to take time. Yeah. And the best thing that they can do is protect in the early weeks and identify the overload and then control load through the rest of the season. So I think they're doing the right things with the end in mind.
Yeah.
The other thing I think is important to share with everybody is statistically speaking, it's very, very, very unlikely that a tendinopathy ruptures.
Right.
Obviously, things happen.
Sure.
But what the evidence would tell us is that those are separate entity injuries. Tendinopathy is tendon pain, and it is almost predictable to come on. Achilles tendon ruptures, there is no preceding pain.
Right.
It just happens.
Yeah.
That's fair.
So if anything, we think about the pain being protective. Like we have a reason to reduce load and change up the way that we've been training in order to protect ourselves from rupture.
Yeah, the vast majority of people had no idea there was an issue, or there probably wasn't an issue, and then they're like, somebody kicked me, right? Like, the standard story,
classic,
right? Like,
right?
Yeah.
Yeah, so we kind of treat those as separate clinical entities and not a degeneration towards a worse problem. The exciting things that are coming out soon, I'm in the California area now. We are going to start, as you mentioned earlier about ultrasound, trying to develop formal training for ATs, PTs, for using diagnostic ultrasound as a clinician in a rehabilitation setting. So rather than looking at it from a diagnostic perspective, but how can I use ultrasound as a form of biofeedback and looking at muscle recruitment? How can we use it to make sure that we are targeting the right tissue with an exercise and our correct cues that we use to make sure that, our athlete or our patient is going to be doing the right thing and using the right muscles. And then, as I mentioned already, looking at it for a way to add context to our clinical impressions. What else is going on around that tissue that maybe could inform symptoms and, the different pain provocations that are coming with our patients.
That's
So we're
brilliant.
going to start that. I've put in a proposal that it should be at the California Athletic Trainer State meeting this year. And we're in talks to try and make something a bit more formal that will be available to general clinicians if they come out for like a 1 or 2 day course.
That's amazing. I mean, it's brilliant.
Yeah,
like
it's
it
a great
really,
idea.
like for sure. And you see people, and a part of like therapy and working out and exercises are using good form and making sure that you're sort of hitting the target. But like you could take it to a scientific level, and I'll sit there and like tap like to try to like make them aware. So something, but like you take that to the next level,
Right.
like by watching it with ultrasound and make sure that like yes, you are contracting.
Yep.
But like and it makes like, why haven't we done this before? It makes so much sense.
It's like it makes so much sense.
Right.
It's like why are we missing this one?
Right.
Clinically,
sure.
like we're missing the ball
That's
here.
awesome.
So yeah, that's it. That all
Exactly,
sounds
especially
great.
for those non-palpable muscles. That's where it's going to be really important.
Yeah, exactly.
Yeah,
for
exactly.
sure. So again, Shawn, thank you so much for your time. I appreciate it. It was good talking to you. I wish you actually could be here in person so we could actually enjoy a beer like we have many a times together. And before we go ahead and close out our tab, we're just going to give a quick shout out to one of our sponsors, and then after we're all done, Shawn, we'll sign off once I stop everything, just to give you a heads up. And then, so yeah, just again, we're going to close out our tab here. We're going to give a quick shout out to our sponsors, Virtual Orthopedics and Spine. They have you covered from runner's knee to dog walker's hip. They have a doc for that. Yard work back and laptop wrist, they also have a doc for that. Virtual Orthopedics and Spine has over 120 providers, over 20 PT and rehab facilities, and more than 25 surgical centers all across South Jersey. So find the right specialist for you at virtua.org/ortho. Neck of the Woods Brewing Company, serving up the best beer in South Jersey. And
Haven't seen Frank in a while.
we do miss you, Frank. We want to get you back on ASAP as soon as we can.
Yeah.
And then lastly, Timber Production, helping us put all this stuff together and getting it out to all our awesome supporters.
Almost had Kyle here today.
Almost had Kyle here today, our guy from Timber Reel, but just schedules happen and life happens. So again, thank you, and we'll catch everybody next time.